Good afternoon. First of all, I would like to thank the organizing committee, especially Prof. Coaches for the kind invitation. So, the prothrombotic causes of ischemic stroke are really very rare, almost 0.4% of the whole causes. We are going to suspect a prothrombotic cause of stroke when we have a simultaneous ischemic and hemorrhagic stroke, or the presence of a systemic disease, or a family history of unexplained cardiac or cerebrovascular disease. From the metabolic causes, I have to mention the hyperhomocysteinemia. We know that even mild hyperhomocysteinemia may increase the risk for clinical manifestations of stroke, probably due to the pleiotropic biochemical properties of homocysteine and its impact on venous and arterial atherosclerotic modifications. We know that mutations of the MTHFR gene can cause hyperhomocysteinemia, but routine screening for this situation after ischemic stroke is not usually indicated. After ischemic stroke and known hyperhomocysteinemia, if we give folate, vitamin B6 or B12 to our patients, we can safely reduce levels of homocysteine, but this from many trials has not been shown to prevent stroke. From the immunological aspect, we know that antiphospholipid syndrome can be a cause of acute or transient ischemic stroke. The diagnostic criteria according to the guidelines of 2006 and the newer guidelines of EULAR in 2023 include vascular thrombosis, in our case, the ischemic stroke, or if we have a woman, pregnancy complications, and also one laboratory criterion which has to be positive between 2 weeks. And this laboratory criterion are the antiphospholipid antibodies, that means lupus anticoagulant, anticardiolipid antibodies IgG or IgM, and anti-beta-2 GPI antibodies IgG or IgM. The clinical range of antiphospholipid syndrome includes the primary type with no clinical manifestations or laboratory findings of other pathological condition, the secondary type, which is due to systemic lupus erythematosus or other autoimmune diseases or malignancies, medicines, or infections, and the catastrophic type, which is very rare, is the injury in 3 or more than 3 organs or systems simultaneously or within a few weeks, with findings of thrombotic microangiopathy and increased mortality. The acute ischemic stroke in almost 20% and the transient ischemic attack in 11% are the most frequent neurological manifestations of antiphospholipid syndrome. Antiphospholipid antibodies are detected in 13.5% of acute ischemic stroke, mainly in younger individuals, and the presence of antiphospholipid antibodies in individuals below 50 years increases the risk of acute ischemic stroke almost 5.5 times. The main imaging findings in acute ischemic stroke and antiphospholipid syndrome are large vessel occlusions, white matter disturbances, small cortical infarcts, or lacunar infarcts. It is well known that antiphospholipid antibodies are able to recognize and target nervous system antigens, possibly through the blood-brain barrier, and they cause manifestations of antiphospholipid syndrome as acute ischemic stroke or transient ischemic attack or many other neurological presentations. What favors the attack against nervous structures and what lies beneath the great phenotypic variability among neurological presentations are still open questions. So, we have to test for antiphospholipid syndrome every unexplained thrombotic or thromboembolic episode, because it is known that in many antiphospholipid syndrome patients, we have some genetic variants that predispose to this syndrome and to thrombotic events. So, if we have an acute ischemic stroke due to antiphospholipid syndrome, we have to give antithrombotic therapy, and the target is an INR of more than 3 or 2.5 in combination with antiplatelet therapy, which should be long-lasting. The role of thrombophilia, on the other hand, with regard to arterial thrombosis, is not yet well established. Disturbance of the coagulation hemostasis system in patients with hereditary thrombophilia promotes the formation and progression of atherosclerotic lesions by activation and accumulation of platelets, monocytes, and macrophages in the endothelium and endothelial vessels, leading to endothelial dysfunction. So, we have to examine if we have the factor V laden mutation in the heterozygous or homozygous form, the prothrombin mutation, and deficiencies of antithrombin and proteins C and S. But disorders of the coagulation cascade have weak or no association with ischemic strokes in adults, and in children there is occasional association with ischemic stroke. There is always the risk of overdiagnosis, that means positive tests with no clinical significance, or false positive tests in acute stroke phase, and also there is unproven benefit of anticoagulation. We have to test for thrombophilia young patients with recurrent stroke with no risk factors and when there is high suspicion of thrombophilic disorders. When can we examine for thrombophilia disorders? Genetic tests can be performed at any time, but functional tests such as proteins C and S, antithrombin, APC resistance, and checking for antiphospholipid antibodies must be done not close to a thrombotic event, not while on anticoagulation, but after 2 weeks after stopping antagonists of vitamin K, after 2 days after stopping DOACs, and more than 24 hours after stopping heparin. If we have abnormal findings on coagulation testing, then antiplatelet therapy is recommended. Anticoagulation might be considered when we have recurrent stroke of undetermined origin and inherited thrombophilia. Then long-term anticoagulation might be reasonable. What we need is well-designed studies that will take into account all limitations, timing, subtype of stroke, race characteristics, which are required to get the right answer, whether thrombophilia testing is necessary, and at what exact time after ischemic stroke, especially in patients without history of documented cardiovascular risk factors. We have some cases where there are gray zones. For example, we have a patient with an acute ischemic stroke. He has a patent foramen ovale. He is younger than 60 years old. So, according to the guidelines, the cardiologists proceed with PFO closure, but he has also a strong thrombophilic, inherited thrombophilic disorder. So what are we going to do? Maybe there is need for antithrombotic therapy after PFO closure for a very long time. As for the cerebral sinovenous thrombosis, if we have a patient with cerebral sinovenous thrombosis and inherited thrombophilia, maybe he needs permanent anticoagulation. If recurrences or prothrombotic condition with a high thrombotic risk exists. Also, we have hematological diseases which are inherited and have a high thrombotic risk. So the risk of stroke in sickle cell disease is almost up to 30%, and the 75% of stroke events are arterial ischemic. In sickle cell disease, due to increased blood viscosity, we have sickle cell infarcts in the small vessels of the brain. Due to anemia, the oxygenation of the blood decreases and the blood flow to the cerebral circulation increases. And also, increased circulating products of hemolysis modify the metabolism of nitric oxide, promoting vascular inflammation and metabolic stress in the brain tissue. In sickle cell disease, after an acute cerebrovascular accident, we can proceed with blood transfusion exchange. The prevention of recurrent stroke is achieved also through red blood cell transfusions and hydroxyurea, which increases hemoglobin F levels and reduces sickle cell clotting and formation. Also, from the inherited hemoglobinopathies, thalassemia, especially thalassemia intermedia, has almost 5 times more probability to develop a thromboembolic event due to chronic hemolysis, insufficient erythropoiesis, excess of iron, decreased levels of proteins C and S, and activated platelets, which are predisposing factors of infarcts in patients with this hereditary hemoglobinopathy. Paroxysmal nocturnal hemoglobinuria, PNH, is a clonal disorder due to a pGay somatic gene mutation of hematopoietic stem cells, resulting in deficient expansion of GPI-anchored proteins, which are CD55 and CD59 proteins. Pathophysiological mechanisms of thrombophilia are induced by released procoagulant microparticles, free hemoglobin promoting platelet activation, altered cytokine profile, defective fibrinolysis, and complement activation. So we can see stroke as the first manifestations in up to 44% of patients with PNH, and we can treat them with inhibitors of complement, such as eculizumab, which is a humanized monoclonal antibody that blocks the complement C5 compartment. Also, we can give ravulizumab or pegcetacoplan, which are the newest anti-inhibitors of anti-complement inhibitors, and also full anticoagulation. From thrombotic microangiopathies, we can have hereditary deficiency of Adams 13 metalloproteinase, and so in this case, transient ischemic attack or stroke would be the first clinical manifestation. We can give anti-complement drugs, or we can proceed with plasma exchange and a new drug according to the EAST guidelines of 2020, which is caplacizumab. We have also hematological neoplastic diseases with many mutations, such as the JAK mutation in essential thrombocytosis or primary myelofibrosis, and less and more rarely chronic myeloid leukemia with Philadelphia chromosome, which can manifest as an ischemic stroke. In acute promyelocytic leukemia, which is a unique subtype of acute myeloid leukemia, we have chromosome translocations, and we can have life-threatening coagulopathy and rarely acute ischemic stroke, and also multiple myeloma due to hyperviscosity and monoclonal gammopathies due to the same reason can appear as transient ischemic attack or stroke. In conclusion, prothrombotic condition as a cause of stroke is a rare situation. We have to evaluate clinical data and routine laboratory tests in young patients with recurrent stroke events and with no risk factors. We have to examine antiphospholipid antibodies and also some usual prothrombotic mutations, such as mutation of factor V Leiden and prothrombin mutation. If there is an underlying condition, we have to treat it if it is treatable. We have to give as a standard therapy antiplatelets, and anticoagulation should only rarely be considered. Thank you very much.